Over to you, Dr. Sar.
Good afternoon. Thank you, sir, for the kind introduction. So my talk today, it is about underdiagnosed condition in the general medical setup, but it is much more prevalent in the society, and it is of great clinical importance as well. Osteoporosis. So, as the name implies, osteoporosis means fragile and weak bones. So it is a systemic skeletal disease with reduction in bone mass due to qualitative skeletal changes, thus increase the bone fragility and there's high risk of fractures. So the cause for this low bone mass, the main culprit is actually something we all have to go through. It is increasing age. Up to age of 30, there is increase in bone mass. And a person reaches his or her peak bone mass by the age of 30 to 35. Then on, there is gradual reduction in bone mass, but this is much more prominent in the females due to hormonal changes associated with the menopause. So if you take the pathogenesis, there is two main factors that determine this low bone mass. First one is failure to achieve the peak bone mass at the age of 30 or 35. This is mainly determined by the genetic factors. The second one is the one that we can modify. It is the imbalance between the bone resorption and bone formation. This is influenced by many external factors like hormones, drugs, nutrition, and various other compounds. The main regulator of bone metabolism is in fact the osteocyte. There are three components that were secreted by the osteocytes that regulate the bone metabolism: Rank-L, sclerostin, and FGF23. The Rank-L, this activates the osteoclasts and thus increase the bone resorption. Whereas in sclerostin, it inhibits the osteoblasts and reduces the bone formation. And FGF23, this acts on kidneys and increase the phosphate excretion. So in fact, all three compounds are negative markers for bone metabolism. These increase the bone resorption and reduce the bone formation. The positive marker is the osteoprotogerin. So this we interpret as a ratio, osteoprotogerin to Rank-L. If that ratio is high, that means the bone formation is higher than the bone resorption. So hormones like estrogen and vitamin D, they increase this osteoprotogerin to Rank-L ratio and increase the bone formation. And hormones like parathyroid hormone and steroids, they reduce this ratio and thus increase the bone resorption, causing the negative effect. Having talking about this pathogenesis, after that, let me present you about two patients that we came across in the past year. This first patient, she's a 72-year-old lady, and she came for her routine medical clinic visit. And as in many other medical clinics, she had to wait for a long time in queue for her turn. And when she stands up from the bench, she had a syncopal episode and she fell on the ground. So we admitted her and did some investigations. This episode by itself was in fact a postural syncope. So we addressed that like postural syncope, but she had a long-term back pain. So we did the lumbosacral spine X-ray, which showed severe osteopenia. Then when we did the DEXA, you can see that we found out there is osteoporosis. Second patient. This is a male, 58-year-old heavy smoker, and he was a fish vendor. We found out that he has been self-medicating with prednisolone for some time for his COPD. He came to the ward with another COPD exacerbation. But on inquiry, he had a history of fracturing the wrist while lifting some heavy boxes. So we did the DEXA. Again, it was osteoporosis. So you can see both these patients, like in many other patients with osteoporosis, came to the board with something else. And osteoporosis was purely a incidental diagnosis. We got the diagnosis of osteoporosis because we actively looked for it. Otherwise, we would have easily missed that. So why is this common condition this much underdiagnosed? There are several factors. One, it is usually clinically silent unless there is a fracture. Second one, there is lack of awareness among general public and clinicians alike. Of course, I agree that osteoporosis is no longer a mysterious illness. We know quite a lot about that, but still, our diagnostic and therapeutic thresholds are suboptimal. Third one is the lack of resources. We simply do not have the facilities to diagnose osteoporosis. This is not limited to Sri Lanka. This is a worldwide burden. There's 1 in 3 females and 1 in 5 males over the age of 50 will at some point suffer an osteoporotic fracture. That is 8.9 million fractures annually. And they have estimated that by the year 2050, there will be an exponential rise in hip fractures. 84% of patients with osteoporosis are either not properly tested or not properly treated. But more than 50% of these fractures can be prevented if we detect this early and start simple treatments. So now most of the specialists they agree that osteoporosis should be made more of a public health priority. The problem with osteoporosis is you don't have to wait until you reach the osteoporosis range to have a fracture. So you can see in this chart that most of the non-vertebral fractures and hip fractures occurred in the osteopenia range. So even without radiological diagnosis of osteoporosis, you can have fractures. So there are few questions that we should be able to ask. Who should be evaluated for osteoporosis? How is it diagnosed? And who should be treated? And what is the duration of treatment? And what should we do when the patient has other secondary risk factors, especially steroid use? First question, who should be evaluated? Current recommendation is any patient, not patient, any person rather, age of more than 65, male and female alike, should be evaluated for osteoporosis. And in the age group of 50 to 65, if they have other secondary risk factors, again, they should be evaluated. Younger patients, that is, persons age less than 50 years, if they have risk factors like fragility fractures, high-risk medications including steroids, any other hormonal problems like hypogonadism, hyperparathyroidism, or systemic illnesses like connective tissue diseases, malabsorption syndromes, then they should also be evaluated. How do we do that? By DEXA scan. This DEXA, dual energy absorptiometry scan. This is the gold standard of the diagnosis of osteoporosis. By doing this, we measure the bone mineral density and then we interpret as standard deviations from the healthy adult population. In the demographic population of postmenopausal women and males aged more than 50 years, in these patients, we use the T-score as the cutoff. So, if the T-score is less than minus 2.5, we diagnose them as osteoporosis. Between -1 to -2.5, we call them as osteopenia. This T-score is a comparison to a sex-matched young healthy adult population. But patients outside this demographic group, that is premenopausal women and males less than 50 years of age. In these patients, we can't use the T-score because it is less reliable. So in these patients, we use the Z-score. It is compared with sex and age matched healthy population. And if the Z score is less than -2, then call them not exactly osteoporosis, but we call them as low bone density, which is expected for the age. Usually, bone mineral density is measured in the spine and the hip, but in some instances, we use the forearm, especially in overweight and obese patients who cannot simply get up to the DEXA table, and in patients with hyperparathyroidism, where the cortical bone loss is more pronounced than the trabecular bone loss. Bone mineral density by itself is not that much accurate, so we need to assess for the fracture risk as well, because even the osteopenic range can have fractures. So we do this by calculating the FRAX. FRAX is an online tool. This calculates the risk of fracture in a 10-year duration, major osteoporotic fractures and hip fractures in 10-year duration. We have a country-specific FRAX, and for Sri Lanka, we have a specific FRAX for us. So what we can do is, we can select this Sri Lankan specific FRAX online, and we can insert the details of the patient. These details include bone mineral density and some other secondary risk factors as well. By doing that, we calculate the risk of fractures, major osteoporotic fractures, and hip fractures. So, if DEXA is not available, what can we do? Because there's only few places in the government sector that DEXA machines are available. To my knowledge, it's only 4 places. But still, we have options. First, we can calculate the FRAX without bone mineral density, because bone mineral density is only one component of the FRAX. There are several other factors in the FRAX. They have found out that even without bone mineral density, the FRAX calculations are very reliable. There's not much statistical significance in the difference. Second option is, we can do this vertical fracture assessment. We do this by simply taking thoracic or lumbar spinal x-rays. So if the patient is more than 50 years of age and he has a vertebral fracture, this is highly suggestive of osteoporosis. So we can start him on treatment without waiting for DEXA. FRAX itself is not perfect. There are some limitations. So to address that, now there is increasing use of this new FRAX Plus score. This addresses some limitations of the FRAX. So in the FRAX, there are some clinical risk factors that are overlooked. These were included in the FRAX Plus. In the older FRAX, some older patients might be undertreated and underrepresented. That is also addressed in this new FRAX Plus score. In the FRAX Plus score, they have added these additional measures as well. Once we diagnose the patient as having osteoporosis, there are several tests that we should do. So in any patient with osteoporosis, we should do the calcium and phosphate levels, vitamin D levels, and complete biochemistry profile, including the liver and renal profiles. But if we suspect any other secondary causes, then we can do the hormonal profiles, autoimmune panel, and urinary calcium and phosphate excretion, etc. Then the next most important question, who should be treated? So current guidelines give 3 indications for treatment. In the demographic group of postmenopausal women and males more than 50 years of age, if they have history of fractures, history of fragility fractures, they should be started on treatment. If they have a T-score minus 2.5, that is in the range of osteoporosis, they should be started treatment. And in the patients in the range of osteopenia, that is T-score minus 1 and minus 2.5, then we need to calculate the FRAX and then start the treatment according to the FRAX. The FRAX cutoff for these patients for the Sri Lankan population is somewhat different from the international guidelines. So for the Sri Lankan populations, FRAX cutoff is for major osteoporotic fractures, it is more than 9% rather than 10%. And hip fractures, it is more than 3%. If this is there, we need to start treatment for the osteopenic range patients. Treatment by itself is threefold. So, as the basis or foundation, you have the lifestyle modifications, and then there are two pillars of treatment: calcium and vitamin D, and osteoporosis specific pharmacotherapy. As in many other medical illness, lifestyle measures are very much important. These include proper exercise regime, weight bearing and resistance exercises, prevention of falls, adequate dietary calcium and vitamin D intake, avoidance of heavy alcohol use, smoking cessation, and patients should be advised to avoid high-risk medications like steroids as much as possible. So patients should be adequately educated and guided for these lifestyle measures. What about calcium and vitamin D supplementation? Does this prevent fractures? This is somewhat controversial and a gray area. Uh, in a study they have conducted in elderly community dwelling people, they have found out that calcium and vitamin D by itself does not reduce the fractures. But in a much older study conducted in elderly institutionalized people, they have found out in those patients, calcium and vitamin D supplements have prevented fractures. So, current recommendation is every patient should have adequate dietary calcium and vitamin D intake. But if there is dietary insufficiency, or if the patient is having hypocalcemia or vitamin D deficiency at the time of diagnosis, or if they have any malabsorption, intestinal problems that impairs the calcium and vitamin D absorption, in those patients, we should start supplementation for calcium and vitamin D. Next part is the osteoporosis specific treatment, osteoporosis specific pharmacotherapy. There are two major types of drugs, antiresorptives and anabolic compounds. So most of the patients, the first choice of treatment is an antiresorptive, preferably an oral bisphosphonate, and we commonly use oral alendronate for it. But some patients can't take alendronate. So these patients include patients with esophageal disorders, gastric bypass surgeries, and patients who cannot meet the dosing requirements for alendronate. Those that cannot sit or stand upright for more than 30 minutes. So in these patients, we can go for either IV bisphosphonate or some other medication. But if the patient is altogether contraindicated for bisphosphonates, like in chronic kidney disease patients with low GFR, then we have to start them on something else. How the bisphosphonates acts? It is by inhibiting the osteoclasts. So bisphosphonates, they bind with the bone tissue and inhibits the osteoclast action, thus preventing the bone resorption and increasing the bone mass. Because of this uh, resorption by the bone tissue of bisphosphonates, there is an increased skeletal retention time of bisphosphonates. This leads us to follow the principle of drug holiday, where we can stop the bisphosphonates after some time and then follow the patient up. So if the patient does not have any significant risk factors for fractures, and if his T-score is reasonably okay, we can start treatment and continue that for 6 years for oral drugs and 3 years for IV drugs. But if the T-score is very low or if there is fractures, we have to continue this for 10 years for oral and 6 years for IV, and then reassess the bone mineral density and decide on drug holiday. The alendronate effect was determined by this FORSIT landmark trial, and it shows that there is reduction in fractures and increase in bone mineral density with alendronate use. If the patient has very low T-score at representation, or history of recurrent or repeated fractures, then anabolic agent may be the preferred pharmacotherapy for those patients. Anabolic agents include parathyroid compounds like teriparatide or rosuzumab. we give teriparatide, we give it for 18 to 24 months. The Vero study that with teriparatide and risenronate, it showed that teriparatide is actually more effective than the this bisphosphonates in fracture prevention and increasing bone mineral density. But the problem is, if we start them on anabolic agents like teriparatide, once we stop that, we have to continue an anti-resorptive agent as sequential therapy because otherwise they will have gradual reduction in bone mineral density. So to preserve this bone mineral density gains, we have to continue anti-resorptive agent once we stop teriparatide. Romosozumab is a new agent. It has a unique action because it has dual effect. It increases bone formation by activating the osteoblasts, and it reduces bone resorption by inhibiting the osteoclasts. So romosozumab is actually the most effective agent as in use today, and it is more effective than alendronate and teriparatide as well according to the studies. Few words on denosumab. Denosumab again an anti-resorptive agent, and it inhibits the Frankel. You can remember Frankel is it increases osteoclast action. So by inhibiting Frankel, we inhibit the osteoclasts and reduce the bone resorption. Freedom and the Freedom extension trials were the cornerstone for the denosumab treatment, and it shows that compared to placebo, it is very effective in prevention of the fractures. Denosumab we usually give for patients who are intolerant for bisphosphonates or who are contraindicated for bisphosphonates, like in chronic kidney disease patients. And in patients who are unresponsive to bisphosphonates, again we can consider denosumab as a sequential therapy. But there's another problem with denosumab. We can't stop denosumab prematurely. If we stop denosumab prematurely, there is this rebound phenomenon that causes multiple fractures and hypercalcemia. So, if we start denosumab, patients should be adequately educated about the need of long-term therapy with denosumab, possibly lifelong. What about the hormone replacement therapy? Because this was used as a treatment for osteoporosis for some time, and there is clear evidence of estrogen and progesterone reducing the fractures. But the risks, because of the risks associated with the hormone therapy, it is not considered as a primary treatment modality anymore. There's high risk of thrombotic episodes, both arterial and venous, and high risk of cancers as well. So, unless the patient cannot be given anything else for osteoporosis, we don't usually use hormone replacement therapy. Okay, so for the last part, what should we do when the patient is on steroids? When to start treatment for the osteoporosis? Steroids is a very high risk factor for osteoporosis. So currently, prednisolone equivalent dose more than 30 milligrams for 30 days or cumulative dose of more than 5 grams is considered as a high fracture risk steroid dose. How does this act? It causes apoptosis of the osteocytes and osteoblasts, reducing the bone formation. It activates the RANKL and it reduces the osteoprotein, causing increased bone resorption. On top of that, it causes muscle wasting, hypogonadism, and reduction in intestinal calcium absorption as well. So all these factors come together and causes reduction in bone mass as well as bone strength. So current guidelines recommend starting treatment for osteoporosis depending on patient's age and dose of the steroids. So in the demographic group of postmenopausal women and males more than 50 years of age, if they have a fragility fracture or bone mineral density is less than minus 2.5, then irrespective of the steroid dose, we have to start treatment as in any other patient with osteoporosis. But in the patients in the region of osteopenia, then that is decided according to the steroid dose. If the patient is taking more than 7.5 milligrams prednisolone equivalent for more than 3 months or more than 30 milligrams equivalent for more than 1 month, in these patients, we should start prophylactic treatment. This is for the osteopenia group. Then patients outside this demographic group, that is premenopausal women and males less than 50 years of age, Then the decision to start pharmacotherapy is individualized. We need to calculate the Z score and then decide on whether to go for pharmacotherapy. In the end, osteoporosis is in fact an underdiagnosed condition, but it should not be so for a much longer time. DEXA is the gold standard, but we still have some other options if we don't have DEXA facilities. Patients might not always need treatment, but if they need treatment, do not hesitate to start treatment. And the basis of the treatment is the lifestyle modifications, so we need to advise them on proper lifestyle modifications. And you need to keep in mind that most of the fractures can be prevented by proper treatment. Thank you very much.
Thank you very much for preparing and presenting a very lecture.